Good morning. My name is Chris or Christopher Martinson. I've got this right here. Today I'm talking about Case Connection 2 for the UNE Medical Biochemistry course. So for this case connection, I decided to pick cases 3 and 4. Case 3 starts off with a 5-year-old boy coming into a pediatric clinic stating that his mother stating that he has frequent urination, excessive thirst, he's kind of tired and sickly. We get to do a serum insulin test on him, and we see that he has very low serum insulin when he comes in. We also do it with a glucose load test, and we see that his numbers are still very low. They rise the same amount as a normal person percentage-wise, but overall he's about a sixth to an eighth of what the typical person has for serum insulin. Looking at this sheet right here, we can see that he has 0.8 millunits per liter compared to the 6 of a normal and 5 compared to 40 of a full-grown adult. So right away we notice with his symptoms and that serum insulin that he likely has type 1 diabetes. We see that he has these very low insulin levels. He's got these symptoms, the excessive thirst, the frequent urination, and these are all very similar to hyperglycemia. So going into kind of the second part of this question, based on these symptoms, his serum insulin level, this patient probably has elevated glucose levels. And this is because with the lack of insulin, he's not able to properly transport that glucose out of his blood into his skeletal and liver muscle. So I used a few different resources. The big one for that part being a Mayo Clinic website, Symptoms and Causes of Diabetes. So looking at that, we can kind of see these symptoms match with what he's having. So then the next part of this is, well, why would he start to develop type 1 diabetes? And it's typically something you see in younger children. So as he starts to get older, he has an autoimmune type of reaction or attacking of the beta cells within his pancreas. These beta cells are responsible for producing the insulin. So if he does have this destruction or damage of the beta cells, that means that there would be less cells, or they would lose that ability to create the insulin. Sorry. This lack of insulin, again, leads to that blood sugar being elevated, not being able to get to the glucose. So then the final part of this question looks into what sort of regulatory enzymes are being activated by this. So the increase or the decrease in serum insulin levels leads to an increase in cyclic AMP. This cyclic AMP activates PKA, protein kinase A. That is one of the two regulatory enzymes. In addition to this being activated, this also activates hormone-sensitive lipase. So these two enzymes are likely to be active in this individual, which can be seen with the lower level of serum insulin. Moving on to the second case connection, case 4. This one, you have a 2-month-old female presenting with a bunch of symptoms, including jittery spells, hypoglycemia. We see that her blood glucose doesn't increase, but her blood lactate increases when she is given epinephrine. We also see that she has hepatomegaly, or an enlarged liver. So with these symptoms, we kind of want to figure out what's going on. What is the diagnosis? So with anything with any type of medical disease, you want to have a few different ideas and kind of go through these differential diagnoses, cross them out, and get to the final diagnosis. So this question gives us 4 differential diagnoses. These are hereditary fructose intolerance, galactosemia, glycogen storage disease, and glucose 6 dehydrogenase deficiency. So, give me 1 second. So, when we're looking at this patient, we want to note all of these symptoms and also some of the things as far as typical lifestyle of the baby. And we don't get too much from this question, but we do find out that so far, this baby has really only been feeding on breast milk. The mother hasn't done anything else. We know that there is hypoglycemia. We know that there is a reaction to epinephrine that increases epinephrine, but does not increase blood glucose. So going through these, we can kind of start to knock away one at a time until we get to the final answer. The first one to look at is kind of based on hepatomegaly being a pretty big symptom. And so with a lot of these diseases or diagnoses that have been mentioned, 3 of them, you can see hepatomegaly pretty common. The last one, glucose 6-phosphate dehydrogenase deficiency, you typically see problems more with the spleen and less with the liver. So right away we can kind of eliminate this as an option, and now we're kind of moving forward with 3 of them. So, and I kind of got most of the information on these diseases on rarediseaseinfo.nhi.gov. These websites have kind of a lot of frequently seen symptoms, questions, testing, things like that about all these different diseases. So the next thing is hereditary fructose intolerance. This is something you'll see pretty early on. You'll see an enlarged liver, so that makes sense. However, the problem with this is that the infant, the child, would have some difficulty with processing and correctly utilizing that fructose. However, if this baby has really only been on breast milk, the likeliness that they've gotten fructose, unless the mother has been consuming excess amounts in her diet, is pretty low. Breast milk doesn't typically contain fructose, and that was found through a study from Simon Perinatal, about the composition of breast milk, which kind of goes over what makes it up, which is primary glucose and lactose, or galactose. So knocking those two diagnoses down, we are left with galactosemia and glycogen storage disease. These 2 share a lot of symptoms. The time frame is pretty close for either of these. However, when we go into the symptoms, and especially that epinephrine increasing the blood lactate, we can kind of get rid of galactosemia and identify the disease as glycogen storage disease. So the later onset, the 2 months compared to 2 to 4 weeks, which is typical for galactosemia, is one of the things that limits it. But there are other symptoms, the jitteriness, which could be a problem with muscles, the inability to use the glycogen, even when there is epinephrine added, which should increase glycogen production, or I can't talk, I apologize. Glycogenolysis, sorry. It should increase that, so you should see an increase in blood glucose, which you don't. So based on that and the inability to utilize this glycogen, this likely leads to the baby being diagnosed with glycogen storage disease. So those were the 2 cases I did. Thank you and have a great day. Bye.